Think we can get started? Hello, everyone, and welcome back to our grand rounds. We're excited to have you join us today. Before we begin, a quick note about next week. Please return for our CPC grand rounds presented by Dr. Heather Manuel. Her talk titled "A 73-Year-Old Female Patient Presents with Shortness of Breath" promises to be both engaging and educational. This week, we are thrilled to present an Institute for Clinical and Translational Research lecture titled Generative AI in Healthcare, Where We Are and Where We Are Going. This session is delivered by Drs. Daniel Morgan and Catherine Goodman. Dr. Daniel Morgan is a physician, epidemiologist, and tenured professor of epidemiology and medicine. He serves as the director of the Center for Innovation and Diagnosis and is a founding member and former director of the Society for Healthcare Epidemiology of America Research Network. Dr. Morgan has also served on the board of directors and as chair for IED Week of 2022. At the VA Maryland Healthcare System, he directs the epidemiology department. His research focuses on topics such as probability in medicine, medical overuse, diagnostic stewardship, infection prevention, and the integration of AI in healthcare. Notably, Dr. Morgan was awarded an NIH New Innovative Award for his work exploring clinician risk understanding. With continuous federal funding, over 200 publications, and frequent media coverage in outlets like the New York Times and the Washington Post, his contributions to the field are both impactful and far-reaching. Dr. Catherine Goodman brings expertise in evidence-based healthcare epidemiology, antimicrobial stewardship policies, and the application of machine learning and prediction models to healthcare epidemiology questions using big data. Her research leverages large claims databases and employs advanced informatics techniques such as natural language processing to analyze electronic health record data. Before pursuing her doctoral studies, Dr. Goodman practiced FDA law in Washington, D.C. Her interdisciplinary work bridges the fields of law and public health, with current collaborations focusing on equitable and legal allocation of scarce medical resources during public health emergencies and the legal regulation of clinical algorithms and emerging AI technologies. Please join me in giving a warm welcome to Drs. Daniel Morgan and Catherine Goodman.
All right. Thanks so much. Okay, can everyone hear me okay? At least in the room. All right, wonderful. So Dan and I, well, Dr. Morgan, but we're pretty informal. So if I tend to talk with my hands and I move around, so if you can't hear me at some point, just someone raise a hand and I'll move back towards the microphone. But we're going to tag team today and flip back and forth in our talk, so you'll hear from both of us, but I'll be kicking things off. Okay, so after that very warm introduction, what Dr. Morgan and I will be talking about today is generative AI in healthcare, where we are, and just as importantly, where we're going. And neither of us have any industry funding or relevant disclosures or conflicts of interest. We do note, though, that you'll see a lot of industry screen grabs in our talk today. And really, I think that's reflective of what we think is problematic in this landscape currently, and that a lot of these products are dominated by a few large tech companies, but you'll hear more from us about this later. So in the next roughly 45 minutes or so, what you'll hear from us is just at base, if we're talking about generative AI in healthcare, we need to explain to you, well, what does that actually mean? What is generative AI at a high level? Then we'll talk about where we are currently in the clinical landscape and where we are going. We'll also talk a little bit about what we believe is most promising about these technologies, but also most concerning. And then we'll finish with a little bit more open-ended about how do we think clinicians need to be prepared for these coming changes. Okay, so what is generative AI in healthcare? We hear the term, particularly in the last year and a half, AI is everywhere. You can't go anywhere. You can't read the popular press without hearing something about someone doing something in AI. But specifically for generative AI, well, what does that actually mean? So generative AI has been called the third AI epic, or AI 3.0. And that contrasts with earlier machine learning and frankly statistical technologies that some have put in the AI 1.0 bucket. Then we had more predictive AI, which we'll talk about in a second. That's AI 2.0, and really generative AI, that's AI 3.0. And I think what I want you to take away from this talk, I mean, this is a really helpful figure and framework that was in JAMA last year by Hal et al. And his collaborators. But at base, I think we care less about, okay, is it 1.0, 2.0, 3.0, but really what does generative AI bring to the table that's new and different and valuable? And I've highlighted here in particular two unique attributes that really set generative AI apart. The first is that, at least for the large foundation models, so ChatGPT, that's a chat bot, but it's underlying models, GPT models. These are foundation models. Really, what's unique about them is that they can perform many different types of tasks without seeing new data to be trained on or without actually retraining them. And so if you change your prompts, which I'm sure at this point everyone has put in a prompt into ChatGPT, you can actually get new model behaviors and new outputs without retraining. The second is that these models, and in particular what we'll focus on today, are the large language models, or LLMs. They can take as inputs free text language, or called natural language. So things that sound like human language, and they can actually respond to them with human sounding or free text outputs. And that's very different than earlier predictive AI models. And so to make this further concrete, I think it's always helpful to have an example. So when we talk about predictive AI or AI 2.0, really, this should look familiar probably to many in this room. We're talking about a model where on the left-hand side of the equation, you have your set of inputs. And for clinical applications, these are often, for example, patient demographic and clinical characteristics. We might have age, sex, comorbidities. But what's important to take away from this is that all of these inputs are in what's called structured, well, almost always structured data formats. So they're in standardized formats that are machine readable. So all of our ages, for example, might be in standardized numerical form. Sex might be coded as a 1 or a 0 or an unknown. They're standardized, they can be read by a machine. Then we have some model or a classifier that takes those inputs, learns relationships between them, and outputs a structured output that is normally quantitative or numerical. So that might be a predicted probability, for example, of a clinical condition of interest like diabetes. It might be a predicted class, a prediction of diabetes, yes, no, or it might be a risk score. But again, it's a structured output, it's numerical. Generative AI, and specifically large language models, they're very different. And so here on our left-hand side, we have a free text, natural language, human sounding input, which is a prompt. I do a lot of, as was mentioned in my intro, a lot of antimicrobial stewardship and resistance work. And so CRE is a type of very bad bacteria. So, everyone in clinical research, for better or for worse, loves acronyms. So this was an example from earlier this year, but you ask ChatGPT, come up with a study name acronym for research that will investigate CRE carriage in hospitalized patients. And then that foundational large language model will actually then interpret that prompt, and output a free text, human sounding response. We can debate whether its acronym HICARE is any good or not. I can also quibble with the fact that it said Enterobacteriaceae, even though that's now been updated to Enterobacterales, but you get the point. This is very different than a structured numerical output. And if I change that prompt, I will get a new output. And that's all without me doing any retraining or changing of underlying data. Okay, so with that sort of high level overview then, I think where we wanted to start is just actually, where are we today in clinical medicine? So what are the current applications of LLMs? And by this, the next few slides that I will walk through, I do not mean hypothetically or research, I mean actual clinical use applications, which is really quite staggering to say, because Dan and I presented this talk, a similar talk earlier this year. We were not fully here yet, and this is how much has changed in just a couple of months, which nothing in clinical medicine with technology normally moves this quickly. So earlier this year, we also had a viewpoint in JAMA, and we had talked in our intro, basically had said that in the long term, LLMs may revolutionize all these aspects of medicine, but that in the short term, it's really the everyday clinical tasks that we think LLMs will change the most quickly and with the least scrutiny. And I think, fortunately, our predictions came to pass, because that actually, in the ensuing year of 2024, has been exactly right. And things have changed even more, I think, than we were expecting. So the first LLM application that is now in clinical use is for clinical communication. And so this is an example of my chart from Epic. Other vendors have different portals, but as a clinician, you've maybe used this to interact with patients, or we're all patients as well. We've probably used this to interact with our clinicians. This is something where the use of these patient portal messaging systems exploded during the pandemic, and it's become a real source of administrative burden and burnout among clinicians, and a lot of pajama time after hours responding to this deluge of messages. And so there was a study about a year and a half ago that was actually evaluating GPT-based models and LLMs for responding to patient questions. These were on a public internet forum. These were not clinically, but this was widely publicized at the time. But what they found, and what has been continued to be borne out since then, is that on these metrics of sort of quality metrics and also empathy metrics, large language model responses ranked on average much higher than physician-generated responses. I think, though, this does underscore that we're still trying to figure out, for these types of applications, really what are the metrics that actually matter, and how do we measure them in a rigorous way. And that is one gap in the literature, but most of the studies to date have been looking at things like perceived quality and empathy. And what I'll underscore here is just that, if you recall from the previous slide, that was from April of 2023. That was on internet data, like patient messages, sort of like on Reddit, for example. But already now, just earlier this fall, it was news to even us how widely these tools had now already been integrated into Epic and deployed across healthcare systems. And for a lot of clinicians and even patients, it took seeing this in the New York Times to realize that this was actually something that had gone live across many systems around the country. We knew certain pilot sites that had been piloting it, but hadn't realized how quickly then Epic had actually turned that on live as a module that health systems could use. And so, this sort of happened under our noses, but is already now and different institutions have different policies. Some will only allow the LLM to respond to more administrative things, of like a question of when is my appointment, or how to schedule a follow-up. Others allow it to be a little bit more open-ended. So there's some heterogeneity there in terms of the guardrails they've put on these LLMs. The second application, and this is something that is also being piloted at the University of Maryland Medical System, is using LLMs as basically AI scribes. So for clinical documentation and summarization of visits. Is there anyone in this auditorium that's used one of these tools as part of the pilot project at Maryland? No. Okay. So they are being piloted, and that trial has been ongoing since earlier this year, and is set to finish in February, but maybe will be extended. So I want to just give, because again, a picture's worth 1,000 words, a video is probably worth 10,000 or more, about a minute or so of a demo of just what do we mean when we talk about this tool. So hopefully this will, so I just need to, give me one moment. So for this, I have to switch, sorry for those on Zoom, to be able to toggle ahead, I need to shift this. So we're gonna accelerate to about the 53-second mark, and I'm just gonna be quiet and let you listen.
Basically picks up the cell phone, asks George if it's okay to start recording. After that, it's a completely natural experience. So the DAX mobile is then put down. Physicians' eyes are free to make eye-to-eye contact. Hands are free as well. Physicians no longer burdened by having to take notes in real time, having to remember any details of the conversation. Fundamentally, what we're attempting to do here is bring joy back to the practice of medicine for physicians worldwide. This patient happens to have presented with complaints of something called chronic fatigue. So this could be super simple, like you need to get a little bit more sleep, but it could be super complex and could be an advanced disease state. So these transcripts can be super long and involved, cover a ton of territory. A 10-minute encounter can literally produce several pages of transcript. Then when the episode is complete, generative AI takes over again, and then within seconds, this transcript is turned into clinical documentation. This is, for lack of a better description, it's called a SOAP note. subjective, objective assessment and plan. It's basically clinical documentation formatting. All the relevant details are captured and the irrelevant details are ignored. So what you've seen here is.
Okay, so I'm going to stop it there. And we'll come back to this idea of, notice how he said all the relevant details are captured and all the irrelevant are ignored. We'll come back to that idea. But basically what that then does is the summary is sent to either the clinician's phone or into Epic for editing, review, and finalization. And again, this is already being used, piloting at Maryland. But when I say pilot, it's because the system is trying to decide whether it's worth purchasing a full system-wide license. It is not piloting in the sense that it is still experimental. Other health systems are using that, it is being used clinically. So let me go back to the other mode now.
DAX listens,
Okay,
generative AI
pause
converts.
this. That was just in case it didn't work. So basically, as I said, then, this is already being used clinically, but somewhat scarily, we still have very little data about how well does this product work. So unlike the video demo, in fact, transcripts have not been provided for these products to date. That is something that's in beta, but is not widely available yet. So we actually do not have at base a core sense of how often do errors enter these summaries. The idea is that the clinician will catch them, but we don't actually have hard data around that. What we do have is a little bit of evidence trickling out about more system-wide metrics of EHR, how much time are you logging into the EHR, other financial metrics. This was just published very, very recently, and this was a study from Atrium Health. But basically what they found was that after controlling for a bunch of variables, they didn't find statistically significant differences in their primary analyses for either EHR usage or financial metrics around visit times or number of patients seen when using these products. What I will say though is that in their subgroup analyses, they did find a lot of heterogeneity. So for a certain subset of about 20% of the clinicians using them, it actually shaved more than an hour off their time using the EHR or pajama time during the day or night related to documentation. And they found that for those, they didn't see changes in financial metrics because in fact, the clinicians were using that time not to see more patients, but they said to sleep more, to spend less time working at home, et cetera. So again, we just don't have very much data yet to understand exactly how these products are working. Their versions keep getting updated, but this is a space to watch closely. Okay, so now I'll switch to Dr. Morgan and we'll talk a little bit more about where are we going.
All right, so I get to talk about the most exciting part, I think, about these tools, that although it's very easy to get some of these products out quickly because they're not regulated for summarization and scribes and whatnot. I mean, I think that the technical aspect of what LLMs are capable of is very interesting when we think about diagnosis. So diagnosis, of course, is a complex process. It requires piecing together lots of information from the history, from the physical exam, from laboratory, other results, the chart, et cetera. And this is very back and forth type process, part of kind of the art of medicine that we often don't describe that well. And it's one that, even clinicians often have problems with, right? There's always talk of diagnostic error being relatively common or, issues around not making the appropriate diagnosis. And a lot of the way we sort of train diagnosis or talk about diagnosis clinically are things like cases or CPCs. So this is a New England Journal CPC, is probably the most famous set of CPCs that are out there. And this is just one example that I'm putting up here just so to remind people sort of these, because one of the first studies that came out related to diagnosis and just trying to see what these machines are capable of took a lot of New England Journal CPCs and is by a friend, Adam Rodman, who actually is a medical historian, but he was interested in the history of using machines in medicine. And so as soon as GPT 3.5 came out and then 4, he decided to feed it lots of New England Journal CPCs, and they did this quickly and published right away. Didn't get it published in New England Journal, but got it published in JAMA. And they looked at how accurate it was. And of course, like actually looking at, is something accurate on these New England Journal CPCs is a little bit tricky because like, how do you compare it to doctors? Like, you have the answer that's in the journal, but there's this bond score. And essentially, the machine did better than probably most clinicians would do. That 64% of the time, it picked up the actual diagnosis within the differential. And this is pretty impressive when you do it on your own. Like, you can try what they did, basically just cut and paste the whole CPC and put it into Chat GPT-4 and say, like, give me the most likely diagnoses. You can force it to give you the likelihood of each, or even what you should do after each. And it gives you pretty complex answers. So this received a ton of attention. I think it's been cited something like 400 times already, and it just came out last year. So it started to show some of the potential for doing this. And then I think one of the most interesting studies that has people thinking a lot about what would be possible is this one. This was out of Google. And so this is where they're trying to look at this tool they developed called AMY, which stands for Articulate Medical Intelligence Explorer. Essentially, it's a chatbot that goes back and forth with a patient. And then they studied it in a randomized controlled trial with standardized patients that compared either a doctor or a chatbot, this AMY program, and they had that only interact over text. So this made it blinded, so they couldn't tell, so the patient couldn't necessarily tell who was the computer and who was the doctor they were interacting with. And so you can see an example here. Someone's talking about chest pain and ask them for more information. And you can look at this online and see how it sort of goes through in a more video type fashion. But it gives sense that there's a back and forth. And then they evaluated these cases, and they had a lot of cases. I think they had 149 scenarios, so lots of different medical cases. They had primary care doctors in Canada, the UK, and India. And then they scored them in a blinded fashion, and they either had the patient actor score them or the specialist physician who was outside of this, who wasn't being involved in the actual research on this tool. And what you can find is the AMY tool is in pink. So that's the larger circle. So it did better generally. And it especially did better on things like empathy in a management plan. And it did similar in terms of things like top 3 diagnostic accuracy and patient's confidence in care, et cetera. And when you really drill down on diagnosis, this is a comparison of the primary care physician versus AMY as far as the accuracy of diagnosis. And what you can see is that generally the program did better at making diagnoses than the primary care doctor in these standardized cases. So again, this isn't exactly real medicine. This is a standardized patient that has a script, and they've worked out these cases. There's a lot like, the OSCEs, the exams that most medical students do. But, it's something we think of as a pretty good assessment of how well people's clinical ability is with medicine. And so people, thought about tools like this and are very excited about the idea of trying to roll this out to basically extend the reach of medicine. So in areas that are, say, under-resourced in low and middle income countries, or even the United States, potentially chatbots will be used in this way. And this was another study that looked at kind of a slightly different format of this. And again, this is a group from Stanford and a lot of doctors who do work on diagnostic excellence. And they did a randomized controlled trial, and they were looking at doctors essentially with and without GPT-4. So they had access to GPT-4 and they could use it in any way they wanted, or they just did what they normally would have. And they were interviewing standardized patients. And then they also pasted the script for this scenario with the standardized patient into GPT-4. So just had the computer do it on its own. They didn't interview a patient. They didn't do a back and forth, but they just had the entire scenario. And sort of the top line that got a lot of attention, like in this New York Times article, was that doctors did worse than OpenAI GPT-4 at clinical vignettes. It scored better on this kind of global assessment of accuracy. And the doctor's clinical reasoning didn't improve with GPT-4, which was interesting, which would imply that doctors aren't really using it when they had access to it, which it seemed true. They were able to look at the logs of, things that people entered into GPT-4, which was just like, basically like a blank box that they could paste in any information they want. And they found that doctors asked questions like, what are the causes of cirrhosis? But they didn't, just paste in the entire case and see what it would diagnose. So it's not exactly a comparison of doctors versus GPT-4. But I think it does, again, bring up some of the potential for what these tools can do technically. And then this is just a follow-up to this. This is by the same group of people that I'm involved with some too on some of the other measures, but it's showing that the new GPT models or the new OpenAI models, this O1 preview, what's called preview here, but it's O1 is the model they're working on, that forces more clinical reasoning into the chatbot does even better. So across these metrics, so one of these is a management reasoning score. And they found that physicians with resources did about the same as physicians with GPT-4, and GPT-4 alone did somewhat better than them. But this O1 preview did much better on this standardized assessment. And that was the same case with diagnostic reasoning. So it does seem like the models are getting better at the technical aspects of providing the right answers for cases. But I want to be clear that this isn't real life medicine. This isn't saying like, here's a patient in a room and either you can talk to the computer or you can talk to a doctor and let's see how accurate it is. This is these are these very kind of clean, well curated information systems that provide all the information to the computer the way that we often have test questions for students, but not real life medicine. So in real life, these models don't work nearly as well for clinical diagnosis yet, but it gives an idea of what we might see coming when these become better integrated. All right, and I'm going to pass it over to Katie.
Okay, thanks. Okay, so I'll talk a little bit now about in the near term. I mean, certainly, I think a lot of the work around diagnosis and the other is extremely exciting when used well and understood well and validated, but it's not quite in the near term as there's a lot more research and study that needs to happen. But what I'll be focusing on here in a couple slides is really in the near term, what we think are some of the most promising aspects of generative AI in healthcare, but also some of the most concerning, again, because it's coming so quickly. So from the promising perspective, I think both Dan and I really do believe, and having worked very closely with these models day in and day out now on clinical notes, which is what a lot of my research, but very messy, real clinical notes, not curated, information from something from a journal, but the messiness of real notes. I really am continually astounded by the ability of these models to extract meaningful information from those messy data sources in the EHR. So I think both of us do believe that to the extent that these tools might be able to help improve the ability to access information for clinicians from the EHR, which is not very user-friendly, could really be a boon and is something that we're very excited about. The hope then is that in turn, that would also improve clinical outcomes and reduce patient safety events and medical errors. We need high quality studies to evaluate that, but that is where we do see promise. And then of course, as well, to the extent that these tools can reduce some aspects of clinician burden and burnout, that is critically important to free up clinician time to actually do the practice of medicine and not documentation. The flip side of that, though, is that there's also some concerns. In particular, Dan alluded to this a little bit earlier, but it was mentioned, I guess I still am a lawyer, but practice law previously, I did FDA law, and we've written about this earlier, but there really are some serious regulatory gaps when it comes to these types of tools. And while I will not walk you through this very complicated figure, it's not relevant to you. If you want to look at it, you can. But FDA basically has this very detailed guidance about not all technology that's used in clinical care is regulated as a medical device. In fact, only a somewhat small subset is regulated. And right before ChatGPT was released publicly, FDA has, I feel very sorry for them, terrible timing in that sense. Literally a month and a half before, they released this final multi-year guidance about what types of clinical decision support tools they would or would not regulate as devices. And what they concluded basically is that, in effect, there's a large universe of tools that won't be regulated. But if you fall into these different, why is this not working? If you fall into these different buckets, you fall under hold on. Okay, the keyboard must be stuck. And basically what I want to call your attention to is that one of the things that will get you regulated as a device and get FDA oversight is if your decision support tool outputs things like risk scores for a disease or condition or a probability of a disease or condition. And if you recall from one of my earlier slides on predictive AI versus generative AI, predictive AI outputs numbers, probabilities, risk scores. Generative AI often doesn't. It outputs words. It is not at all clear that a lot of generative AI-based clinical tools that output free text language would qualify currently as regulated devices. And indeed, the fact that we have seen some of these documentation tools used clinically in the past year, those did not go through FDA clearance process for medical devices. And so we're already seeing this, that these tools are coming to market for better or for worse without FDA oversight. Secondly, beyond the regulatory aspect, which will provide some guardrails that we think this tool is safe and effective to deploy in clinical care, there's also the aspects of really human biases. And so automation bias, and this applies to both older predictive AI-based tools, but also generative AI too, is this tendency for humans to over-rely on automated information, even in the face of contradictory data. And we know, and it's been established, that this bias can be very strong and absolutely occurs in clinical care. But then in addition, generative AI and large language models raise some additional biases that we don't have with older predictive-based models. And one of these we call Amazon bias. You won't find this in the literature, I don't think. This is our term. But basically, it's this idea that clinicians, especially busy clinicians, will favor what is streamlined when interacting with the electronic health record. A lot of predictive AI and best practice alerts, they're annoying. Clinicians don't like them. Generative AI, in a lot of cases, will be helpful. It will make life easier. And so it's this idea that, you know, Amazon's one-click checkout, which makes it a frictionless process, that is patented and worth billions. Humans like to favor what makes their lives easier. And that's what a lot of these LLM tools will do. Secondly, there's also, again, I don't know if this is in the literature or not, but what we call anthropomorphism bias or familiarity bias. And it's basically this idea that natural language-based outputs that sound human-like can be deceptively cogent. And so it's not easy to see that you're being nudged by these outputs. And you may also be unlikely to check the underlying source data unless you have some reason to suspect an error, something that really seems like a confabulation or what's been colloquially called a hallucination in these outputs. And so putting this together to, again, make this concrete, we had a viewpoint in JAMA earlier this year at the beginning of the year that was basically exploring some of these issues with respect to LLM summarization tools. So this would be the idea of if you had LLMs where clinicians could query in the EHR, tell me about, summarize for me, you know, a patient where all the discharges, all the hospital visits they had in the past 6 months, they're in your ED in front of you. You want to know what happened to them in the prior year. You don't want to dig through the chart. And these were de-identified notes from a data set that's publicly available for research. I want to underscore that. You cannot put public protected health information data into ChatGPT. Please do not do that. These were de-identified. But basically, what we found is we prompted GPT-4 and basically said, you know, summarize recent hospital visits for a patient in the emergency department with suspected, and we either told it myocardial infarction or pneumonia. And we said, provide a succinct, clinically relevant, and accurate summary. And when they had these very long discharge summaries, a few of them from the earlier year, pages and pages and pages of data, all the lab results pasted in, they're very messy. And basically, you know, what we got out is, this is a term that you will see in the literature, and it's called sycophancy bias. And it's the tendency of LLMs in particular to want to give outputs that are what the user or the prompter in effect wants to hear. They are trained through reinforcement learning that they get higher scores by giving you what you want. And that does not mean it's wrong. The outputs that we got, they were accurate summaries of this patient's prior hospital visits. But as you can see, depending on whether it was told that you suspected myocardial infarction or pneumonia, it actually emphasized different comorbidities and clinical aspects about these patients from the underlying discharge summaries. And so again, there's this potential for framing effects of this can actually potentially nudge for better or for worse, clinician decisions and prescribing behavior and everything else. And we don't really have a good sense of what are the implications of that. But we need to be aware that these tools do have these characteristics. And so ultimately, to sum up, we believe that soon, and that this is not hyperbole, that LLMs may become central to some aspects of clinical medicine, that it may be how doctors respond to patient questions on portals or through electronic means, at least as draft replies that they can then edit. In large part, it may be how doctors document care. In large part, it may be affecting how billing occurs. And then sort of more in the slightly more distant future, but potentially will affect how information is retrieved from the electronic health record or summarized, and may guide diagnosis and treatment. And so all of these things may have important impacts for how we train clinicians. And now I'll pivot back to Dan.
All right, great. So let me talk a little bit about maybe some thoughts on what this may mean for clinicians who are interacting with these. And so we wrote a paper that was mostly about AI 2.0 that came out just around the same time as GPT became well known. But talking about how clinicians need to think about probability, and this is something that's known to be a problem in clinical medicine, that it's hard to think in terms of probability and to adjust those probabilities appropriately when we're thinking about diagnosis. And a lot of the AI tools for predictive AI are essentially that. They modify the probability the same way a diagnostic test would. And for these new tools, these large language models, we think we do need education for clinicians. Right now, I don't know of anything that's out there. We developed some tools for testing, like some short videos, a flipped classroom, and then having in-person discussion, at least for medical students here at the University of Maryland that we use. And a game that teaches adjustment of probabilities for diagnostic test information. But I think for large language models, we'll need something a little bit different than maybe the way that many people approach these. So Annals of Internal Medicine recently had a review on large language models. And you don't really need to read this figure carefully, but just to know there's lots of different large language models. Some of these are general, like ChatGPT. Others are more specific to trained on medical data, like the MedPalm tools. And and all of these are created different ways and theoretically should have some different outputs or different ability to give answers. But I think that's probably not the right way to think about these. I think we should really be asking for clinical information and how these perform in certain situations, thinking about these as though they were basically any other medical technology that we use, that they modify the way that we provide care. And we should look at the outputs on that because they're hard to predict based upon just a knowledge of how the model was built itself. So things like at hospital admission, using a large language model to support that admission, like summarizing past admissions, and then looking at patient outcomes, like how does that change things? Does it make the patient have a better diagnosis? Does it make them in the shorter times in the ER, et cetera? Because that's really what we care about. And we can do this with sort of the epidemiological tools that we have to evaluate studies or to evaluate all other tools. And so just to follow up on that, I think we should really be focusing on its performance on clinical task. Even though we talked about these tools being used and like maybe performing better than doctors at certain tasks, no one thinks that they're going to appear on their own to modify care. I think probably out in the community they'll be used. There'll be some apps that people can use at home. But really, this is going to be things that doctors will have access to, and there'll be tools and that we should be evaluating them clinically because there's a surprising capacity beyond the expectations, I think, of just understanding the technology underneath them. They're remarkably fast, and that's really one of the strong points. It takes like 5 seconds for them to read a few discharge summaries versus, any of us who would have to, sit there for 30 minutes. It's great at unstructured data, like reading notes. It's great at generating language, but we really need to look at how it impacts patient care and also be thinking a little bit about how it will be used and how it will be implemented. So this has been done already with DAX and MyChart, the two examples Katie gave, that those basically are like a button you push. Like you say, you know, DAX, listen to my interview and write a note. And then you can modify the note, but you're not asking it to do it differently. You're not saying like, write it in the style of Shakespeare, or write it this way. And that's what you could do if you had a prompt. You know, you could make it your own style and it'd be very different. Versus if we just have an open field that we can ask it to do anything, which, you know, I think is much more powerful maybe, but, you know, scary as far as what it could lead to also, and maybe giving wrong information or changing care in a harmful way. And I do think clinicians will need to change how they practice. So, you know, that video sold DAX is like, just come in and talk to your patient and there'll be a note when you're done. But it's not going to work as easily as that. Just like the electronic health record wasn't a perfect answer to the problems of having a paper chart, that doctors will change their workflow. Just like with the EHR, where doctors spend a lot of time in front of the computer now and not talking to the patient. I think we'll see changes that are needed, like for ambient note dictation, for example, just a very concrete one. If you want to have your physical exam in the note, you need to say it out loud, or else it, you know, won't be picked up and dictated. But I think also doctors will generate less text. They won't be writing notes on their own as much, but they'll have to read them much more carefully. And doctors aren't that great at editing notes. I mean, I see a lot of notes that, you know, have cut and pasted things, you know, automatically brought in from the labs. It may have like long comments that are irrelevant to, you know, the clinical note. But, you know, so I don't think we read our notes very carefully, and we'll need to be reading them much more carefully to see if it's right or not. We'll have to be thinking about these biases. And I think the diagnosis and management tools will have many more potential challenges. And then the last thing I'll mention, this is happening in some places that chatbots are available for clinical care. And so just to restate what Katie said, don't use ChatGPT unless it's HIPAA compliant. And so there are some hospitals where it's HIPAA compliant, like Stanford, some of the Harvard hospitals, NYU, and I guess the VA is even piloting this in some places, where you just have access to it and you can put in clinical data. It won't, you know, sort of go up into the cloud and be available and, you know, reveal patient information. And they usually say, by the way, don't use this for clinical decision-making. But of course, everyone uses it for that. You know, like residents at Stanford will, you know, put in their notes and say, give me a discharge summary, or, you know, give me a sign out that I can give to the other residents. And it, you know, works pretty well for that type of thing. But for that, we really need to think about prompting, that it's a whole different skill set. You know, the way you ask it to do something will determine what the output is. So, you know, Katie and me asking the same question, we think, you know, but if it's not actually the same words, like we'll get different outputs from it. And there's, you know, and there's sometimes limits as far as how much data you can put in. So you can't put, you know, say all the notes for the stay, they'll only be allowed like 2 notes maybe as far as the size of data that it can take. And the last part for clinicians, I think, is really, it's important to practice with these. Even though we said there's this anthropomorphism bias, don't think that this is a human, even though it generates human looking notes. Often, I think the way that we can understand this is to get a feel for it, to get a sense of kind of like what it tends to do, how it tends to write things, you know, sort of these kind of bland notes it tends to write, or if you've ever used like Teams and, you know, summarized a meeting with it, you know, get a feel for what it does so that you can know sort of what it does well and the things that it tends to have problems with. And I'll pass it back to Katie to finish this up.
All right, so in our last few minutes then, we wanted to finish off by opening this up about what broader questions at a high level do we think we, and by that I mean everyone, should be contemplating now. And I think it's critically important, and we both feel very strongly that these are conversations and discussions that need to be happening among the public, patients, practicing clinicians, not just the tech companies, not just the regulators, and certainly not just quote unquote AI experts or researchers that do this work on a daily basis. These need to be broader discussions because it will influence where this goes. So just 2 concrete examples then to ground this. You know, you've heard us talk a lot about potentially LLMs to improve the usability of the EHR. This has a lot of information on this little slide. You can find this publicly online, but it's just to say that Epic already has, these are all the different lists of LLM or generative AI applications that Epic already has available or in testing or in development for changing how we get information out of the EHR. And, this is really exciting. At the same time, though, I think we need to be asking, as I call it, is using LLMs to fix the sins of the EHR a good use of money, and in particular, environmental resources? So LLMs are extremely energy hungry. These companies are actually looking to purchase nuclear reactors to fund use of these technologies. They use a lot of water. So every time we run a prompt, there is an externality and a cost to that, to society and to the environment, that I think needs to be part of these conversations of what is a high value use of these tools and what isn't, when we consider all of those costs together. And then secondly, more patient-facing examples. Again, this is a case where the best of intentions go awry. We sometimes see that in the law. So under the 21st Century Cures Act, there was a provision that was designed to ensure that to reduce diagnostic errors, patient received their information and test results quickly. They couldn't get lost in a care gap. But as a result, it means that now, legally, when test results become available, they're immediately pushed to patients on things like their MyChart portal, potentially before a referring provider has the time to review and interpret them. And so I don't know if anyone else is a fan of The Office like I was, but this is Jenna Fisher. And she was recently talking about her breast cancer diagnosis on Good Morning America. And she said that she was on a hike after receiving a biopsy. I think it was a weekend. And she got an email that she had new pathology results in her MyChart. And she opened it up and she said, I saw words like invasive, ductal, carcinoma, malignant. And I was like, those words sound like cancer words. The point is, she got that information before her doctor could even preface it for her, interpret it for her. And so I think, it's pretty scary that actually there's a lot of startups that are well-funded that are actually designing LLM tools to interpret things like translate radiology reports into 5th grade reading levels, to make these pieces of information more accessible to patients. And I think the question is, do we really want AI filling this gap? I think in some ways the system is very broken in that regard. So maybe LLMs are an improvement over the status quo, but I think we still need to be asking those questions. And there was an interesting op-ed, if you've seen it last week in the Times, talking about healthcare, but also other industries too, but just this broader idea that in some ways human interaction in many of our daily interaction is becoming a luxury good. And I think healthcare is no exception. And again, I think it's incumbent on all of us, myself as a patient and a researcher, and many of you in the audience as patients and clinicians, to be thinking about, are we okay with that? And so our last slide to leave you then is basically bringing it full circle. If we think a little bit, and Apollo, this is just our diagram or schematic of it, it's pretty rough, but of what we call like the evolution of humanity and medicine, we can think of, the Norman Rockwell era of, in the last century and increasing through sort of the early 2000s, this sort of minimal or no digitization. And now we sort of have the early 2000s through the present, where there's increasing digitization. We have the explosion of EHRs, documentation burdens, and really what a lot feel is the loss of humanity in medicine. And I think we do have the potential sort of now and into the near future that generative AI and LLMs are one way that we can help restore some of this humanity to medicine by reducing the burden of documentation and informational tasks. But I think the question we all need to be asking is, where do we want to draw those boundaries? Because this can proceed into the potentially near or distant future, into really augmentation, if you want to call it that, or even in some instances, replacement of human clinician cognitive tasks. And I think increasingly, for those of us that do this work and are knee deep in this research, we think that that is more a values question than a technical question of what a lot of this may ultimately end up possible. The question is, do we want it to, and where do we think those boundaries should be drawn? And that is something that we want everyone involved in those debates. And so with that, we are finished and we're happy to take questions.
Thank you so much. That was a really great lecture. I'd like to open up for any questions from the audiences, both here and on Zoom. We have a lot.
Thanks. That was that was a great presentation, and I really appreciated the equipoise between the advantages of ChatGPT. So research, let's talk about research. This is an ICTR seminar. My equipoise really comes from that because we don't really know about what's in GPT-4 or 5. It's completely unregulated and it's not transparent. Now, it seems to me that even this latest iterations, it can't create new information. It can assimilate what is there. And that then becomes a risk because you talk about biases. And some of clinical data that goes into research is flawed. I mean, what are the really representative groups that have been studied? What is the quality of the research? What is the quality of statistics? Because I think you mentioned this, is that you can get a very, very sophisticated sounding approach, which is actually completely correct. So efficiency, yes, accumulation of a lot of data into a known diagnosis, yes. But where do you see it going in research and new information?
So thanks so much for that question. It's a great question. I think probably I'm interested to hear Dan's perspective on this too. So to take your first part of the question, which is about where do I see it really contributing to research now, I'll hold off on the generating new information part for a moment. I can say for myself personally, I think probably as a methodologist and also having been a lawyer, I like to take things piecemeal. I like to validate. I want to know what I'm doing. And the place that I am currently using these in research and evaluating them, and I'm really flabbergasted by how well they work, as I mentioned previously, is on extracting information from clinical notes. And so in some ways that can sound like a very, pardon my colloquialism, but like unsexy application of LLMs compared to diagnosing patients and everything else. But it's actually something that really dramatically moves the needle forward when you have models or predictive AI where there's lots of characteristics about patients that are important risk factors, but you have no good way to capture them at scale from your data because they're buried in free text nodes. So this is a place where we are really using them on a daily basis. I'm using them in research and I've seen them be really successful. I think, though, for other applications where they're a little bit more the more sophisticated, like summarizing information or summarizing guidance, and that is where, to your point, we need to be so careful about these models are trained on the internet, even ones that are fine-tuned on clinical data. They are trained on the data that exists in the world we have, not, as I call it, the world that we want. And so we need to be understanding of what are the disparities and the prejudices that exist in those underlying data. They are not, because these models will replicate them. We see that for predictive AI too. It's not a new problem, but I think it's a bit of a problem on steroids. But I'm writing actually a viewpoint on this now, but I try to tell students that I talk about this with as well, that that's a different debate to be having. That's not a methods problem as much as a values and a society question of what is fair to allow a model to replicate and what isn't, and also increasingly what is lawful. And that again is why we need not just methodologists or methods experts involved in these conversations, if that helps a little bit, but I'm curious what Dan thinks.
I mean, I feel like on a topic this broad, you could, say a lot of different things. I mean, I do think a lot of what's needed is probably clinical studies and actually saying, all right, this tool is being pushed out to users, like, let's randomize it. Like, let's try to look at like, what is the difference in outcome? And then I guess the other part that I think is what a lot of sort of diagnostic excellence type people are bringing up is like, hey, humans aren't great at these things either. So we don't need to say that machines are perfect. We need to say they're as good or better than like, some kind of human definition, like two experts reviewing the chart and coming up with a diagnosis. And it gets a little murky there, like how you do that and what's acceptable. But maybe I'll stop there just so we can cover other questions. Because I see there's one or two online here. And
so sorry for coming late. I'm just wondering a little bit if you could speak to kind of validation. I think one question I always have with AI in medicine is, are these models being validated? And I'm sure you guys are, the sepsis model, for example, at a couple of years ago, wasn't validated for years. It was running, it was bad. They had to go back and change it. And I think now we have this kind of growing issue of these models being put forth into clinical practice, perhaps without rigorous validation that medications and other things experience. And I think LLMs particularly pose a challenge because unlike other predictive AI, you can kind of have it running silently in the background, and kind of assess that. And so I'm wondering if you might be able to speak to what are potential avenues for governance for kind of LLMs. I know it's a big topic. And then, I think that's, just the governance and LLMs, please.
Yeah, thanks. So great question. I could go on about that for probably an hour or more, so I won't. I'll spare everyone here. But I think the 2 points I'll say are the following very quickly. One, in some ways, I do think there's reason for optimism in that a lot of the reasons that predictive AI often fails, even when validated, to perform well in other populations is just, unfortunately, the basic math of as the prevalence of risk factors changes in populations, the performance of these models changes. In some ways, LLMs are a little bit more robust to those challenges than predictive models. The flip side, though, is that as you underscore, validation and local like increasingly in the field, it is the expectation, not the exception, that you need to validate locally. Well, when we're talking about large language models, that is validating on real messy text, which has PHI in it. You cannot transfer PHI notes across institutions. It is the bane of my existence. I understand why it exists. It makes it extremely hard to collaborate. I have collaborators at Hopkins. We're doing notes-based studies. I cannot look at the notes. They have to describe in generalities, where did the model falter? I actually can't put eyes on it. And it means that how are we going to have institutions do local validation if it's a community hospital without, experts that actually have the time and bandwidth and expertise to do that? There's all these open questions that we have not solved yet. And I hope we're starting to think about at least. So great questions.
And I'll just comment on the sepsis model that got a lot of press, because we kept working on sepsis models forever, and I don't love them or anything, but they're actually, we know much more about how they work than we know how, DAX or MyChart responses, or especially clinical diagnosis tools work. So, that isn't published. Like Microsoft just put it out, and we have it now, and it gets updated every so often. So even, like what we're using now probably won't be the same as like a year from now.
I think in the interest of time, we have time for one more question. Do you think the pendulum will swing where clinicians will be at risk if they don't use these tools in the future?
Sure. I mean, I think that, yes, I think some of these tools will become just like the electronic health record, right? You could be for or against it, but you're going to use it. I think that some of these will probably be that way. And the efficiencies that they provide, like things like for MyChart responses, at least where there's something generated, will make it hard to not use those. So like you'll be kind of penalized by being old-fashioned about it. And I imagine maybe some of the efficiency expectations may occur that you're expected to respond to more patient requests if you have this tool, and then everyone will be held to that regardless if you use it or not. So I do think they're coming. I mean, I'm not a huge proponent of them, but I feel like they're interesting because I think they're gonna come, and we should be looking at them as closely as we can.
Thank you both so much.
Right, thanks.